Hello, today we'll be talking about Alzheimer's disease mainly, but I'll also talk about other dementias. My name is Dima Fatal and I'm an associate professor at the University of Iowa. I've trained in dementia and also balance problems and dizziness, and I direct the balance disorders clinic. I have no disclosures, no financial relationships. Dementia, Alzheimer's disease, AD, is the most common form of dementia. Alzheimer is a slowly progressive cognitive and behavioral process that declines over time. It's a slowly progressive process with prominent memory dysfunction occurring early on. AD was initially described in 1901 by Dr. Alzheimer in a patient, and in 1911 he described in histologic detail the neurofibrillary tangles and neuritic plaques. Alzheimer is very common. In the US, it's estimated that at least 4.5 million persons have AD. And with this number being estimated to go up to 14 million by 2050 because of the aging population. So age is the main risk factor, but there are other factors. Genetics is the second most important factor. 25% of AD is familial, and that means that a person would have two family members. 95% of AD is late onset, and 5% is early onset, earlier than 60. Of the early onset, 60% is familial and 40% is sporadic. 10 to 15% of early onset, which is 2% of all AD, are autosomal dominant. 3 genes have been identified: the APP on chromosome 21, presenilin 1 on chromosome 14, and presenilin 2 on chromosome 1. Other genetic factors have also been implicated. ApoE4 is estimated to be associated with about 20% of AD. One allele increases the risk by 2 to 3 times, 2 alleles by 5 to 15 times. And it also shifts the onset of the disease by a decade earlier per allele. Yet, it's neither necessary nor sufficient and does not for the diagnosis and does not increase the diagnostic certainty, so it is not recommended for routine testing. Another newer marker is the so-called neuronal sortilin receptor and has variations. It's associated with late onset. This website keeps up to date on all the newer genetic findings in Alzheimer. It's www.alzgene.org. In addition to genetics, environmental influences also play a role, including early life exposures such as diet, physical exercise, and cognitive exercise. I will be talking about the cognitive exercise a little more later. Early life modifiers have been found to include things such as head circumference in the first decade, general body growth through the second decade, socioeconomic status, environmental enrichment, and nutritional status. Additional early and midlife factors include head injury, obesity, insulin resistance, hypertension, hyperlipidemia, and obstructive sleep apnea. All of these have been associated to increase the risk. Specifically also for diet, modest alcohol intake may lower the risk of Alzheimer, and midlife diet that is high in unsaturated fats, fish, vegetables, fruits, and legumes is associated with lower risk 2 decades later, while saturated fats have been associated with a higher risk. However, this one study that looked into that only took one snapshot of the diet in midlife and then followed them later in life to check who developed Alzheimer. What they did not find in this study was a weighted effect. For example, in people who took little versus medium versus high amounts of saturated fats, were looked into, and that relationship was not followed by an increasingly more risk of develop AD as you eat more saturated fats, and same thing for the unsaturated fats. So it wasn't a clear linear relationship that worsened the more you took and improved the more you took of the unsaturated fats, but there was a suggestion that moderate amounts of unsaturated fats are helpful, moderate amounts of saturated fats are not. High intake of vitamins such as C, E, B6, and B12 have been associated with lower risks, but when studied, the studies showed inconsistent results. Physical exercise has been associated with decreased risk of Alzheimer's disease. In the one particular study, they looked into people who exercised for at least 15 minutes 3 times a week, and that included things like walking, bicycling, jogging, etc. And they looked at the habits in midlife and then followed them later and found that this was associated with decreased risk down the line. The concept of cognitive exercise theoretically should work, but it has not been found to work. However, in patients who already have Alzheimer's disease, in a recent meta-analysis, found that it does help. And the cognitive exercise included things such as memory pads, helping with the face, with pictures, faces, and names association exercises. Some were given by the caregivers and some more formally. These studies actually were all done for a few weeks only, and in a couple of studies that looked into them down the line found that the gain from these lasted 4 to 5 months. So the effect was a moderate effect on cognition. So there was no side effects or drawbacks. They were all simple techniques, and they helped. Social activities in midlife also seem to decrease the risk. It was a study from Sweden, very recent study. And by the way, I have all the references at the end, or I should say the main references at the end. And if you have any questions about the details of these or the references, you can let me know, and I have at the end how to ask questions. All right, so for social activities in midlife, this study was from Sweden, and it showed that it did decrease the risk years down the line in about 500 older adults. What they found is that people who were socially active and not neurotic and on their personality scale, they were they did not have tendency for somatization, etc. Focusing on, I mean, they did not have tendency to focus on their own self or exaggerate symptoms, etc. They did better down the line. Late life depression has been strongly associated with dementia. Whether it's a risk factor or a prodrome, it's unclear. So an older person with depression should be screened for dementia. The pathology of AD is well studied. There is neuronal loss that results in the atrophy that is seen on imaging. Neurofibrillary tangles correlate with the deficit, not much for the senile plaques. The pathophysiology is presumed decreased clearance of the beta amyloid protein isoforms in sporadic cases, but increased production of the A-beta in familial forms. Clinical history, it's an insidious onset of episodic memory impairment, often includes names of objects and names of persons. There's visuospatial dysfunction, getting lost, or asking for directions on how to get out of a Walmart or a bookstore or something like that. So it doesn't have to be frank getting lost and going off to another city. Visual memory loss also, and examples of that would be misplacing and losing eyeglasses and keys, etc., which we all do here and there, but if it becomes consistent and worsening. Language, there's reduced spontaneous verbal output. Some people have prominent anomia, difficulty with names, hesitancy, word finding, occasional errors, paraphasic errors, and the grammar and the syntax getting progressively less complex. Mid and later stages, you have executive dysfunction, agnosia, apraxia, and neuropsychiatric problems such as apathy, depression, agitation, anxiety, and delusions. The neuro exam is mostly normal. They may have some Parkinsonian features late, and that would be a differentiating feature, for example, from Parkinson's disease with dementia, or dementia of Lewy body, where by definition the dementia and the Parkinsonian features should start within 1 year of each other. So that's an important differentiating point. Mental status exam is abnormal to memory. When we do, for example, the mini mental, they would not remember the 3 words that you give them. And if you give them clues or multiple choices, they will have no clue. So they've lost them. And that would be a potentially differentiating form from other types of dementias, such as, again, Parkinson or vascular dementia, where it's a so-called subcortical dementia, where if you give them multiple choices, that will help them to remember the words that they were tested on. None of this is, of course, hard or set in stone, but these are clues to tell you this is Alzheimer versus other types. The diagnostic criteria, the widely used one is the Diagnostic and Statistical Manual of Mental Disorders, DSM-4, is an insidious and progressive decline in cognitive function, resulting in impairment of social or occupational function, impairment in recent memory, and then in at least one other deficit. So memory has to be involved in addition to one other function: language, apraxia, the ability to use objects, brush your teeth, comb your hair, agnosias, and executive function, planning, abstract thinking, etc. Neuropsychological tests that are most affected is the memory early on. By the end, everything is affected severely. Here, what I'm going to do is go over a mini neuropsych testing, which you can actually practice and try to use if you want, if you're interested, in addition to the mini mental. So to test memory in a little bit more detail would be to give them a 10-word list, such as things that involve nature, clothes, furniture, food, body parts, etc. So you can tell them, I'm going to read you a list of words, and you read one a second. For example, moon, farmer, nose, flower, etc. And then at the end, when you read your list, you ask them what words you remembered, and then they will tell you all the words they remembered out of that list in any order. And you repeat that 4 times. Again, they tell you all the words, even those they have mentioned before. And then you don't say anything, and you do other parts of the exam, and then you can come back 10 minutes later and ask them, what do you remember of that initial word list? Without reading it again. And typically with Alzheimer, they will have little of any recollection. Even if they've repeated several words of that 10-word list, by 10 minutes later, they would remember 0 or 1 or 2. So it's abnormal if they have less than 7 on delayed recall. These are rough numbers. These are not formal neuropsych tests. But the beauty of this is that with Alzheimer, if you tell them, was moon on the list, they wouldn't know it. Their recognition if a word was or was not on the list would be chance, 50-50 chance, versus other types of dementia, such as with Parkinson, vascular, they may have a better recognition. So if you tell them, was moon on the list, they would more likely to say yes. Was sun on the list, more likely to say no. For visual memory, you give them a complex figure. You can draw whatever you want. I just jotted something here, but you can do whatever you want, just something complex, abstract, and they draw it, they copy it, because they can have visual spatial problems, and so the copy itself will be abnormal. And then again, a few minutes later, you tell them, do you remember that abstract weird figure that I asked you to draw? What do you remember out of it? And they if they remember half of the elements or less, then that is considered, roughly speaking, defective. So these would be interesting tools if you don't have a neuropsychologist around you, or if it takes a long time, or if the patient does not have insurance. So you can maybe try those, and they might help you differentiate this from other types of dementias. Other tests are attention, psychomotor speed, executive function, language. These are core tests that are needed to be tested in patients with Alzheimer. And usually they tend to be less involved. They could be abnormal, but tend to be less abnormal as compared to the memory problem early on. On the other hand, things like dementias like frontotemporal dementia will have prominent executive function. Dementias with a subtype of frontotemporal is so-called primary non-fluent aphasia, progressive non-fluent aphasia. They will have a lot of language problems involved. So you could differentiate maybe the different types of dementias based on these simple tests. So for attention, you give them numbers, and they have to repeat after you. These are random numbers such as 27914, and they repeat 27914. And then you can give them 6 digits and 7 digits and 8 digits and 9 digits. And if they cannot recall 5 or more, then that would be it's an immediate answering. So it's not a delayed recall. So they have to immediately answer. It's a working memory test. Then if they cannot repeat 5 digits or more, then that would be defective. And then backwards, you give them 3 numbers, 319, and they have to say 913. If they cannot do that, if they cannot do 4 or more, or 3 or more, if they are less than 3 backwards, then they are abnormal. Psychomotor speed, trail making A and B, these are part of trail B and trail A. These are part of frontal function, especially trail B, because you're shifting. So trail A, you have a paper which has all sorts of numbers on it, and you tell them connect 1 to 2, 2 to 3, etc. And these are timed tests to see how quick they are. People with Parkinsonian problems or subcortical, such as vascular dementia, or people with frontotemporal dementia where they have executive dysfunction, they will have problems with these tests and errors, and they will be very slow. The trail B is similar, but you alternate between numbers and letters. So from 1 to A to 2, 2 to B, B to 3, 3 to C, etc. And language, there's the word fluency. You tell them, tell me all what you think about that you can buy from a supermarket, or list all the animals that you can think about in 1 minute, and then you count how many animals they could list. Or you can tell them, tell me all the words that you can think about that start with the letter C, for example. An abnormal would be if they list less than 10 per 1 minute. And then naming, you give them several objects to name. So again, obviously you don't have to do this, but I wanted to tell you a little bit about the neuropsych testing so it does not remain a little mystery. And then just in case a person cannot afford a neuropsych test, then maybe you can consider doing a little bit of that to differentiate the different types. And while we're at it, people with depression will have memory problems, and they may score low on the 10-word list that we just mentioned. They may have attention problems if they're not sleeping well, and they might be slow because of that. But they should not have naming problems in a sense that they agnosias. They don't recognize, I shouldn't say naming, but they shouldn't recognize, they have difficulty recognizing objects. They should not have apraxia, so they should be able to know how to brush their teeth and comb their hair and put on a jacket and imitate bicycling and imitate whistling, etc. So these could be differentiating points between depression and dementia. So the workup, you do your mini mental, and by definition has to be less than 27. Doesn't mean that you have to treat it, but 27 to 30 is considered normal. You do your thyroid and vitamin B12, just because these are easy to treat and could mimic dementia. I've had one person one time in 10 years that had a TSH of 100, and she came to the dementia clinic. But other than that, I think it's rare in the dementia clinic to pick up a thyroid or a vitamin deficiency problem that is the cause. They could be concomitant and associated illnesses which need to be treated, but they're not likely to be the primary reason. And then, of course, you screen for depression. Imaging, a CT or an MRI, non-contrast, is what the Academy recommends. And it's basically to rule out significant vascular disease, to see if there is vascular dementia or concomitant vascular dementia. And while we're at it, I want to say that it really is hard to say this is Alzheimer, this is vascular. A lot of patients most likely have both if they have one or the other. So the treatment is pretty much similar. You control the stroke risk factors and you treat for the dementia component. So it's not a huge issue. However, with vascular, if they have a lot of white matter disease, they may have a concomitant gait problem and they may need gait training or fall risk prevention, etc. You also want to see that the ventricles are not too huge, to look for NPH, normal pressure hydrocephalus. But for that, the gait should be prominently abnormal. If a person walks very, very well, they turn well, they walk well, they're not falling, they swing their arms, and they're not shuffling their feet and dragging their feet on the ground. Even if they have little big ventricles, you can just observe them. You don't have to refer, but if you want, of course, you can do that. But the key is it's unlikely that a neurosurgeon would want to shunt a person with a normal gait. Tumors, I've had one person who was found to have a glioblastoma, came to the dementia clinic. Think about that person might have had both, because he presented with symptoms of 5 years of memory problems, and the imaging showed a glioblastoma, which life expectancy in an older person, or life expectancy in general, is definitely less than 2 years. So investigational biomarker, but it changes prognosis, and so it should be done. This is why imaging is recommended as a screen. And there are investigational biomarkers. They are investigational at this stage, although some neurologists, some behavioral neurologists are using them. It's a CSF tau increase and CSF beta amyloid 142 decrease, and combined the sensitivity and the specificity approaches 80 to 90%. But at this stage, they are still recommended as investigational. Maybe down the line, shortly down the line, they will be more available. Investigational neuroimaging is with the PET scanning with what's called the Pittsburgh compound B, PIB, and again, it's at this stage investigational. Currently, there is a study in Harvard looking into that. The differential diagnosis, we've already talked a little bit about that, and when we talked about the mini neuropsych testing and the workup and the imaging. So vascular dementia, there's a lot of overlap. So you treat basically, as I mentioned, the same. So it's not maybe too important to differentiate between those, but it's important to image. Depression. Neuropsychological testing can be abnormal on memory and attention, but they should not be abnormal on apraxia, as mentioned, or agnosia or aphasia. So they should not have language problems in a sense of non-fluent, abnormal repetition, abnormal comprehension, agnosia, they don't recognize objects, or apraxia, they don't know how to use objects. Depression, as mentioned, may be the prodrome for dementia or increases the risk to develop dementia, so it needs to follow these people, obviously. Frontotemporal dementia, there's only early personality change. The family members would say this person is not the same person. They will have early executive dysfunction, the trail B. They will have fluency problems, such as the supermarket list in 1 minute, etc. If in doubt, you're not sure if this is frontotemporal or Alzheimer, and you don't have a neurologist or a dementia clinic around, you might try the same treatment, although there is definitely evidence that it does not help in frontotemporal dementia, and it may even cause some agitation, the cholinesterase inhibitors that we use for Alzheimer. But you're not going to, no one is faulted at trying, and then if the person does worse, you can stop the medications. Dementia of Lewy body, as mentioned, the dementia by definition has to start within 1 year of the Parkinsonian features, or vice versa. So they have to start within 1 year of each other. And you treat as if you have two conditions. You treat the Parkinsonian features with Parkinson medicines, and you treat the dementia with Alzheimer medicines. In summary, for the differential, you need to image, you need to check for thyroid and B12, but you can potentially try the same treatment for now. Maybe down the line we'll have the CSF studies, the PET studies that could differentiate, and if we down the line get better treatments such as vaccination or the monoclonal or polyclonal antibodies, the IVIG, then maybe it will become important to differentiate between these different types of dementias. So for treatment is the cholinesterase inhibitors. There's a general guideline that you want to treat when the mini-mental is between 10 and 20, and stop it if the mini-mental less than 10. In general, for Alzheimer, the mini-mental drops by 2 to 3 points on average per year. For donepezil, it is also approved for severe, but in general, you may want to stop the cholinesterase inhibitors once you are below 10 on the mini-mental. But when to start it, 20 plus, and the plus is variable. And the reason is that the effect of these medications may, according to expert opinion, may last a few years, 2 to few years, maybe 2 to 5 years. So if a person, for example, is planning to retire and they want to be, but not immediately, and they want to work a couple more years, so you may want to give them that medicine now, even though they may have 24 or 25 or 26 mini-mental. So you give them a little more benefit so they can do their job a little better, potentially. And then once they retire, if the medicine is not working anymore, you can stop it. And we'll talk about that a little more later. On the other hand, if a person is retired, then and their mini-mental is 26 and they're functioning okay on their day-to-day, they're not bothered, then you may want to wait and give it a little later, so you can give them a little boost when they are worse. So these are very general guidelines about when to use, but I will tell you also a little more about actually what benefit are we getting from these medications. So the cholinesterase inhibitors that we have are donepezil, galantamine, and rivastigmine. And these are the doses that you start with and the maximum doses. And there's a patch for rivastigmine. There's no difference that we could tell from the different ones. And there are a couple of studies that compared a couple directly, and there was no difference. So basically, they're all the same. Donepezil is once daily, the others are twice daily. This is why you will find a lot of people are on donepezil Aricept more than the others. But occasionally a person may not tolerate one and then you switch to the other one. I'm not at all advocating one versus the other. The newer drug on the market is memantine, and it's an NMDA receptor antagonist, and it's indicated by the FDA for moderate to severe. And in Europe, the indication is for a mini-mental less than 20. Here, it's variable, but the VA, for example, uses a mini-mental less than 14. You start with 5, you increase by 5 every week until your maximum 10 twice a day. Okay, so all the cholinesterase inhibitors have similar efficacy. The side effects mainly are GI, and some insomnia, vivid dreams, leg cramps, and bradycardia, so you want to get an EKG. Indications mild to moderate. Donepezil also has an FDA indication for severe. These medications are actually recommended as the standard therapy by the American Academy of Neurology. And the effect may last, as mentioned, 2 to 5 years, so you may want to delay their use, as we already talked about in the example of a patient who's functioning okay, retired, and not bothered on a day-to-day at the moment, so you can delay their use. Memantine, that's the dose again. The trials suggest improvement in cognition and behavior and activities of daily living. It's indicated for moderate to severe. There's added benefit if you combine it with a cholinesterase inhibitor, and the side effects were actually similar to placebo, so it's well tolerated. Okay, now I'm going to raise an important point. There has been recently, in 2008, couple of articles about cholinesterase inhibitors as a group, including with memantine too. Controversy around their use and if it is cost effective. Everyone agrees whether you're for treatment with these medications or against treatment, and I have to say, as I mentioned already, that the Academy recommends these as standard of care. But I want you to be also aware that all the sites and all the studies show that the benefits are small. And on a 70-point scale, the difference was less than 4 points. And the 4 point is an arbitrary set number that the FDA put as a standard for clinical relevance. So really it is minimal, it's a small effect. And we're giving these medications potentially for a few years, and they are expensive. More importantly, for behavioral and quality of life effects, recent meta-analyses have found that they're not very well studied, their results are less consistent than the effect on cognition. The limitations of all these studies is that they were short duration. Alzheimer, when you diagnose it, it's a decade or so long disease. Likely the disease is few years, if not more. So maybe it's a 2-decade or more illness. And the studies looked at a snap of 6 months, and they found a small benefit. There's poor reporting of side effects in the studies, and there's lack of definition of clinical relevance. As we mentioned, less than 4 points, a 1 or a 2 point on a 70-point scale. What is the clinical significance of that? The point that I'm raising this for is to stress to you that if a person cannot afford it or cannot tolerate it, it's not the end of the world. They work minimal, they work for a short time at any rate. Okay, and although it is standard from the Academy, we should attempt to give them, because that's the standard. There are good people who are raising good questions about that. And I think that is important, because maybe studies should not be financed by pharmaceutical companies. But that's also a point that some neurologists are raising these days. It's not only neurology, but probably in other fields too, that maybe these studies should be independently done. At any rate, having said that, there are some things that we can do that seem to also potentially help, maybe a little bit. They have not been compared with medications, but they also help, and we should not ignore them. Exercise, as we talked about, since your primary care, emphasizing the importance of exercise early on in life and midlife, and even later in life. That can decrease the risk of Alzheimer. Another is the concept of cognitive exercise in people who already have Alzheimer. Studies have showed good results, and we do have at the University of Iowa cognitive rehab, but I'm not saying we're the only ones, obviously, and these things might be done by occupational therapy in conjunction with speech and physical therapy for exercise, etc. So these might be useful, important, practical, easy, cheap, and maybe maybe ignored and underused, and medications maybe sometimes overused. Treatment of behavioral problems, depression, SSRIs are considered the first line, since the tricyclics have anticholinergic side effects. And there was one study for citalopram that found that may help with agitation. Otherwise, the SSRIs only help with the depression symptoms or the depressive symptoms rather than with psychosis, etc. Anxiety, again, SSRIs can be used, and it's recommended to avoid the benzodiazepines. For sleep disturbances, mirtazapine has been recommended. For psychosis, hallucination, agitation, and aggression, olanzapine, risperidone have been found to help. However, there's a black box warning about them that they increase the risk of stroke. But I don't want to be talking on behalf of the psychiatry psychiatrist and the psychiatry body, but my understanding is that they keep using these medications in their demented psychotic patients. The Alzheimer medications themselves, the cholinesterase inhibitors, may help with some of these symptoms, agitation, aggression, etc. The studies that looked into those showed mixed results. Many were negative. The two studies that looked into memantine were negative, and the two that looked into rivastigmine were negative. But some of the studies for galantamine and donepezil were positive. So you might want to try those for such symptoms, even if you didn't mean to try them for the dementia itself. There are interesting investigational treatments that are going on, including at the University of Iowa in the psychiatry department. The A-beta immunotherapy is ongoing with the polyclonal or monoclonal or active vaccination. There's the secretase inhibitors studies and the amyloid anti-aggregation with direct A-beta binding or inhibitors of advanced glycation. So there are interesting, exciting potential treatments, and maybe down the line diagnosing Alzheimer's disease correctly and early on would become a more important issue. Driving is a big deal, and recently, just a few days ago, published ahead of time, published on the internet, is the practice parameters from the Academy of Neurology, and I'm proud to say that Dr. Rizzo is at the University of Iowa. The recommendation is to use the Clinician Dementia Rating Scale, the CDR, and I have a slide of that for you to use, as well as caregiver information. What the parameter recommendation is that don't depend on what the patients tell you. If they tell you they're safe driving, that doesn't mean that they are safe drivers. And interestingly, the neuropsychological test, there's no enough evidence to say that we can rely on it and that it can predict who's safe to drive and who's not safe to drive. So what do we do? What we do is this is the clinical dementia rating, the CDR scale, for your information, and there's the full reference down there. Okay, so this is the gist of it. If a person has mild to moderate dementia with a CDR 0.5 to 1, what you do is you evaluate the risk factors. If the caregiver reports marginal or unsafe skills, then that's one. You ask about history of citations, history of crashes, driving less than 60 miles per week, situational avoidance, aggression and impulsivity in their behavior anyway, a mini mental less than 24, and other issues like alcoholism, sleep disorders, etc. So if you have a CDR of 0.5 or 1 and you have no risk factors, they're relatively low risk to drive. If they have multiple risk factors of these listed, even if they have mild dementia, they would be relatively high risk. And if they are severely affected with a CDR of 2, they are already high risk. So it's a useful algorithm to use. And these are the main references that I used. And if you have any questions, please email the Iowa Geriatric Education Center. And I hope I raised some issues about treatment, and hopefully these issues will be looked into down the line with studies that evaluate patients for a longer period of time, and evidence emphasis on prevention more with diet and exercise early on, and emphasis on some cognitive training later on. And thank you very much.